Welcome, everyone. Thank you so much for joining us tonight. Welcome to our 15th, or it's actually 16th, Virtual's Doctors Night Out with our host, Dr. Kellyann.
Hello and good evening, everyone, and welcome to Doctors Night Out Deep Dive, where we take a close introspective look with one doctor with a lot to say. And again, good evening. I'm your host, Dr. Kellyann Petrucci, and tonight is a special night because if you want to know anything about what's going on with this pandemic, you surely have heard about Dr. Perlmutter, who has been posting some of the best information out there every day. Welcome, Dr. Perlmutter. So happy you're here.
I am delighted to be back. Thank you for having me, Kellyann.
Yeah, you're welcome. So Dr. Perlmutter was on our panel before, and he just stood out as such an expert, particularly in this. He has been posting every day about all of the facts, and there's so many. Dr. Perlmutter, it was funny, I was at the store the other day, I was getting some supplies, and I saw a mom, and she looked so tired and so harried, and she had one child, holding one child who was wearing a mask, a very young child, and the other toddler who was running around, and she was screaming, "Don't touch anything, don't touch anything, behave yourself." And I thought to myself, my gosh, so many people are being affected in so many ways. And I thought, we just have to get through this. We have to get through this. So now we've got all this going on with people who they're all questioning, do we stay at home or is it time to be released? Is it time to go out into the public again and open things up? What do you think? I mean, what are the advantages and disadvantages that we have right now, people wanting to get back to work? And are these antibody tests, are they the answer?
Well, Dr. Petrucci, let me say that, this has become a very polarized level of contention, not only in our country, but globally. And I think that there is important information on both sides of this discussion. I didn't say argument. And that is, on the one hand, we know that close contact with other people will spread this virus, and that some people who get this virus will die. We'll discuss, I think, later on in our third hour or fourth hour tonight, that's a joke, how serious of an event this is. But that's an argument for isolation in the face of what we see going on in our country right now, with many states backing down on their restrictions, basically opening up. So there is no right or wrong here. I think that both sides can win. We can do the right thing and allow people, I believe, to go back to work with provisos in place, providing that there is adequate testing, that the tests are meaningful, and that individuals at work are afforded a level of protection. And that's really important because, not having a job, not having an income is a life-threatening situation for many people as well. We have to be realistic about that. In an ideal world, everyone would just go into their houses for the next 6 months and wait till scientists create some magic treatment and then come out of their houses. That's not going to happen. So on one hand, we have countries in which there has been an incredible degree of isolation, both governmentally and self-imposed, and where their results have been phenomenal. And on the other hand, you have countries like Sweden, for example, where their main health minister, Agnes Tegnell, has indicated that they're going to pretty much let people rely upon social responsibility as opposed to mandates from the government. And this is a country in which businesses are open, that many schools are open, and life goes on. And what have we observed in a country like that? Well, their death rate is per 100,000 around 24 to 27, in comparison to Denmark and Finland, where the death rate is around 7. So the death rate currently is higher, and we could look at that and say, that's a really high death rate, but it's not as high as Belgium or Great Britain, for that matter. And truly, what Dr. Tegnell has talked about is this idea that they are within weeks of herd immunity. So that is playing the long game. What does it mean? It means that they are letting things open up and happen, let things come what may, with the long game. In other words, they're going to get to herd immunity a lot sooner than in places where there is restriction.
Explain herd immunity for those that don't
I will.
understand.
And they are really behaving in a way designed not to flatten the curve. In other words, the idea of just getting it over with. And I'm not arguing one way or the other. I'm simply presenting this for your viewers to noodle this a little bit. So herd immunity is the concept that we reach a point where enough people in the environment have been infected and are now immune that the virus can no longer effectively spread. Now, we look at a metric to determine when we've reached that, and the metric is called R and then sub-0, or R naught. And when R naught is 2 and 3, it means the number of people that an individual can spread to. It still means that we haven't reached that level where the virus is going to shut itself off. But once we get down to a point of 50 to 70% of people having immunity, then the virus no longer has anyone to grow on, and we've essentially cut it off. That happens only under 2 circumstances. Either it happens when you've had the disease and you've now created antibodies and are, let's say, immune, or there's been the development of a vaccine program that then allows you to have immunity by virtue of that intervention. So that's at least a year away, despite some recent news,
Yes.
if not 18 months away. It really then leaves us with looking at the dynamics of getting infected. Are we restricting infection in hopes of not overwhelming our hospitals and resources, or are we sort of allowing infection vis-a-vis Sweden, in which case a certain number of people will get infected? Yes, a small percentage will die, but you'll build to herd immunity a lot sooner. Again, I'm not arguing one side of this or the other, but I'm simply saying that what makes sense, at least for me, is to watch day by day how this unfolds, how it develops, and then begin to think about recommendations based upon real-time activity, about what is really happening as we watch this unfold.
So we are hearing a lot about these antibody tests and them being available to the public. Can you explain the antibody test? Do you think that that's going to make a big difference in the outcome? And I know that there's the IgG and the IgM. Can you explain those to everyone?
Sure. So we defend ourselves based upon our immune systems. And our immune systems are kind of broken down into 2 major categories. We have what's called our innate immune system, and that lives within us and has been, it's a gift that we have that allows us to react immediately to any sort of infection or any sort of invasion of our bodies. So that's the first line of defense. Then we have a system called the adaptive immune system, where certain cells in the white blood cell lineage, we call them B cells, are primed to then create antibody proteins that will react specifically against a bacteria or against a virus, very, very specifically, like a lock and key. And they are, in addition, we create what are called memory cells that remember that event. And to some degree, we're able to remember an event lifelong, or maybe just for a couple of years. We know that, for example, it looks like our polio vaccines work, pretty much through our lifetimes, as do smallpox, although there's some indication now that smallpox, many of us may not have smallpox immunity, despite the fact that we were immunized as children. But we have this system whereby now, confronted by COVID-19, our immune system says, hey, that's a foreign invader. We're going to create these antibodies that allow our immune system to recognize, call attention to the virus and gobble it up, which is a great thing. Now, the first antibody that we create is called IgM, and that is an acute antibody production that peaks out relatively soon, in a matter of days to weeks, and is followed by a much longer term production of another antibody called IgG. So this isn't really that complicated. The 2 antibodies to think about are the first one that happens, IgM, and then the longer term IgG. So many of these antibody tests that people are getting measure actually both of them. So let's talk about what the results would look like And what does that mean? Well, if you went and had an IgG and an IgM test and only the IgM was positive, it would mean that you're fresh off this infection and may still carry the virus. So if you just have IgM, it means that you were just infected, even though you had no symptoms or minimal symptoms, or you had terrible symptoms, and you still may carry the virus. Both of these antibodies do not tell us that you do or don't harbor the virus, that you are or are not infected. Wow. That's important.
Yes.
But if you have IgG, that's long-term, means you're further away from your infection. Likely you're not infectious or infected anymore, and likely that is licensed then, as it's being interpreted, to allow you to go back to work, because likely you won't infect other people, and likely now you have a pretty good chance, I believe, at being immune. Now, interestingly, there is some data that's come out of South Korea. The Korean CDC, or KCDC, looked at 7,829 people who had proven COVID-19 via nasopharyngeal swabs, actually tested for the virus. And afterwards, when they were feeling better, they were again retested on 2 occasions with negative testing. They then returned after a period of time, and lo and behold, they were retested via this genetic molecular test, and once again were positive. And this, raised some concern. About 2.1% of the 7,829, 8,000 people, about 2.1% had tested positive. And that's not playing by the rules. You know, we didn't like that. We think you get it, you go through it, however you experience it, bad or good, and then you're immune. Go back to work, go back to school, and resume your life. So this was troublesome, and this was published about 3 or 4 days ago, and it raised a lot of eyebrows, a lot of concern. But the data that came out today, or at least the rehashing of this information and asking what it really meant, presented something very interesting, and that is that in some of the cells in the lung that may actually be shed, end up in the nose, end up in the pharynx, carry, in a sense, a fingerprint of the virus, not actual infective, active virus, but sort of a genetic fingerprint, if you will, and that might have explained the positive tests when these patients return. The other explanation is that the first 2 tests that they had that showed that they were now negative may not have been fully accurate.
Yes.
So like the story in Sweden, we're going to need to watch this as well. But this virus is behaving in ways that we've not experienced before, and it is very stealthy, it's very conniving, and it's getting its way in many regards. I think one of the biggest issues that we're seeing this time around is this notion of the asymptomatic carrier, meaning people infectious, can spread the virus, and they feel perfectly fine. Hey, I'm going to come to your house. I don't have a fever. I feel great. Can I come over? No, you can't. So these are the people that we worry about. These are the people who, when they get off a plane and have a temperature check, on their foreheads as the screening technique, they fly through with, they go through with flying colors, and yet they could be carriers and, they could be spreaders. So this is something that we're not used to. We don't see it with typical rhinovirus. We don't see it with typical influenza. And we don't know yet the degree of, what percentage of out there are these asymptomatic individuals. The first report that came out of California about a week and a half ago was somewhere around 3 to 6%. And then there was a report in New York that was 14%. And then more recently, a study that came out of Chelsea, Massachusetts, that showed a third of the sample, people randomly sampled, 1/3 tested positive for antibody. We'll talk about what that positives and false negatives in just a moment.
Yes, please.
But a third, and one recent, very interesting study that we need to talk about more in a moment, appeared in the New England Journal of Medicine. And it was a study of a couple of hundred women who went to the hospital to deliver their babies. And very few of them tested positive, but of those who tested positive, 90% were asymptomatic. Think about that.
That's
90%.
unbelievable.
When I talked about that study on my podcast, I said, you know, this is really interesting, such a high number of asymptomatic carriers, but importantly, we need to ask why that is. What is it about being pregnant that may well allow you to carry the virus and yet have no symptoms or perhaps minimal symptoms? And I think that, and also the fact that men are being involved with this and hospitalized at a rate that is as high as 2 to 1 in comparison to women, makes us look at what is the difference between men and women. And, you know, there are a lot of differences beyond hormones, but I think the first place that most people have gone to has been hormones. So we now see interventional trials being carried out in New York where patients are being given estrogen in comparison to those who are not given estrogen to determine outcome. And in Los Angeles, they are actually looking at progesterone as an intervention. And interestingly, we know that men who have low levels of estrogen receptivity actually have been demonstrated in previous research, well before our current situation, to have bad outcomes as it relates to respiratory viral infections. And we know that estrogen is involved in both the innate immune system, what resides within us, and the adaptive immune system, what we develop, this whole antibody thing that we've been talking about. But I would say that moving forward, I expect that we're going to see more research exploring the differences between men and women beyond hormones. I think it's important to recognize that estrogen is not a female hormone. Testosterone is not a male hormone. Cholecystokinin is not a gallbladder hormone. You know, that these things are represented in all of us, and that, you know, progesterone is not just for progestation, that progesterone has a role to play in immune modulation, in cognitive function, in regulation of inflammation in both men and women. So I think we kind of, you know, paint ourselves into a corner when we talk about male hormones and female hormones. We know that many issues in women's health are strongly impacted by testosterone. That, you know, part of bioidentical hormone replacement in women oftentimes looks at, as a measurement, free testosterone levels and uses testosterone in women for things like fatigue and for libido, for example. So similarly, we know that, again, so-called female hormones are very active in men. So we've got to get away from that. And beyond that, another bit of data that I think will be relevant moving forward is we understand, as it relates to immune function, that about 70 to 80% of autoimmune conditions are found in women. Things like rheumatoid arthritis and multiple sclerosis, for example, systemic lupus erythematosus, or lupus. These are primarily women's diseases. So there may be something about carrying that other X chromosome as opposed to the Y chromosome that characterizes males that may have a bearing on that. And I'll tell you why it's the extra X chromosome that may be a factor. There is a situation called Klinefelter syndrome. And Klinefelter's, oddly enough, is XY, like a male, but has an extra X chromosome. So they're XX with a Y. And guess what? Their rates of autoimmunity are the same as women. So there's something very interesting about that extra X chromosome. And when I say extra, you know, understand that in women, both X chromosomes are not fully expressing themselves. That cells are actually a mosaic where one of the X chromosomes is suppressed and the other is fully or near fully expressing itself. So I think moving forward, we got to think about, why do women get autoimmune conditions? Does it mean their immune systems are jazzed up? Yeah, it probably does. How do we treat those conditions? By immunosuppression, as one example, with steroids and other immunosuppressives. So, that is certainly something that we need to consider.
And I think that should be your next book, for sure.
No, it was just written.
Okay, well, we just missed it, but that's
by
very
Dr. Lisa Mosconi. It's called The XX Factor. And it's a wonder. I might even have it right here. I don't see it.
That's unbelievable, because I have not heard that. And that's very interesting. And that's going to be a really big tell for many of the diseases.
Well, she didn't talk about the autoimmunity thing, but she talks about the role of being female. How females are underserved in general in Western medicine in terms of drug development, in terms of testing. And B, what is the reason that women get Alzheimer's disease twice as often as men? We have to think about that.
Yeah, very interesting. So back to the antibody test for a minute. These are very sensitive tests, right? So if you get the results, can we be sure that they're the right results?
No.
And secondly, how do we get our hands on them? And are having these tests, are we going to get to a point where in order to enter back into the workforce, is everyone going to have to take these?
The immunity license, as is now being looked at in Europe. Let me answer question one, and that is, how accurate are they? And the answer is, unfortunately, not very. There are some good ones. I think the one offered by Quest Diagnostics is good, very good. But there are plenty of them out there. Some of them have not been FDA approved. Some, I think 7 have been. But nonetheless, they're good, but they're not great. They are showing, a small percentage, but significant, of what is called false positive, meaning says that you now have the antibodies, but the reality is you have not yet developed antibodies against COVID-19. Why might that be? Because many of us, most of us perhaps, have had coronaviruses of one sort or another in the past. Coronaviruses are not new. They were described in the late 1960s, identified right at the beginning of our use of electron microscopy, where the virus was visualized and it had a ring around it, looked like a crown, hence a corona, the coronavirus. So we've known about these viruses for a long time. And that said, it is thought that the new antibody tests can cross-react with previous antibodies that you've developed from having a coronavirus in the past. That's the false positive. Well, if that's 4% false positive, you think, well, yeah, it means 96% accurate. Yeah, but it's not necessarily a good thing for that 4% of people who now think they're in great shape, going to go back to work, and could have a real issue. So I think that's really important. At the same time, there is a similar percentage of false negatives whereby the test doesn't identify the presence of the antibody. So people then are, getting the message that they've not yet had this virus, are not able to go back to work. They don't have the immunity license that they talk about, and therefore might miss out on having that ability. So, but I do believe that the quality is improving week by week. And, the timeframes we're looking at right now, when they're saying, it's going to get worse again in the winter, we're not going to have a vaccination program until 18 months. So when we say that something is going to improve week to week, that's, instantly, that's in the very, very near future. And we're absolutely seeing that happen. Now, as to your question number 2, the availability, that is expanding through the private sector, I might add, dramatically day by day. I mean, I receive emails pretty much on a daily basis offering me, the ability to buy hundreds of these tests for point of care tests, whereby you can do it and have your answer in 5 minutes. So, the answer you get, it appears on a little plastic reader, much like a pregnancy test. So, they're not fully accurate, but answering question number 2, very rapidly becoming available nationwide.
How does that compare to the original testing that was being done, where they would do the swab? What is the comparison?
So the original test, the molecular test, looks for the very specifics of the genetics of that organism, that unique organism. The rate of false positivity and false negativity is significantly less. It's a super accurate test, but it's not 100%. And we've learned that. And that's the argument, for example, when we see that the patients are suddenly testing positive again and they tested negative before, we know that there can be people who are tested negative but still have virus, and people who are tested positive and don't have the virus, although that's very, very rare. So this is a test, we would say, more of the presence of the virus as opposed to the presence of the antibodies that your body has now produced in response to having that virus or not.
So as we start to reopen and we're understanding testing better, what did we learn from the 1918 Spanish flu? What did we learn from that we can kind of take part and parcel and use that knowledge for now?
Well, we're learning a lot based upon reviewing that history. I mean, that was an event that that was, killed 40 million people. That is during a time when we didn't have acute care, invasive procedures, ventilation, and all of that. But our population was obviously a lot lower. Now, I think some of the important take-homes from that experience are that when we let our guard down, the second wave, the backside of the hurricane after the eye went through and everybody thought things were great, was worse than the first wave. And I think that's a valuable lesson. I think that once the guard was let down, it was let down aggressively. And I don't see that happening now. I mean, as we begin to open up, I think that governors around the country are really hedging themselves by saying, we are going to slowly open up. We're going to have 25% or 50% occupancy in restaurants, whatever it may be. We need you to keep your distancing and encouraging the use of masks, and very important, frequent hand washing is powerful. So these are things that were not necessarily talked about back in 1918, which I think will help mitigate moving forward in terms of how aggressive our second wave, which we will have, but how aggressive that will be. The other thing that we learned back in 19 that I think is very, 1918, 19, and 1920, that I think was actually very instructive was even back then, in a very primitive way, there were blood components from people who had recovered that were being given, transfused into people who were very, very sick. And even back then, as crude as that was, the death rate was reduced by 21% in those individuals who received this type of treatment. We know now that our ability to harvest plasma and therefore antibodies from convalescent individuals is far more advanced. We have the ability, or developing the ability, to amplify antibodies, which is called monoclonal antibody therapy. And the preliminary studies coming out, one that was published in the Journal of the American Medical Association actually earlier on, have been encouraging, with people really regaining their health much more quickly. And that is not immunization, that's a form of treatment, that's offense. And I think ultimately that what we should expect to see is what's going on in China, and that is bringing a lot of things to bear at one time. Whether it's their suite of antivirals, using Arbital, which is a Russian antiviral. Some are actually using hydroxychloroquine as part of their protocols. And, it's one thing to be able to have one variable, study hydroxychloroquine, study remdesivir, whatever it may be, but it's, then you get good information about that intervention. But it's another thing to use a suite of ideas and hope that you just help that one patient. It's similar to Dr. Dale Bredesen's approach to Alzheimer's disease, where he says, yeah, taking this drug is interesting or that drug is interesting, but we're going to do 36 different things for these Alzheimer's patients. And guess what? He gets positive results by doing that. The idea of monotherapy is something pharmaceutical companies want us to do because it shines a spotlight on their unique product. But I think we should be open to the idea that vitamin D, intravenous vitamin C, perhaps hyperbaric oxygen therapy, in combination with remdesivir, with who knows what else, zinc, hydroxychloroquine. All these variables can be looked at in combination, I think, to possibly bring about improvement.
So I know that there was some encouraging news out of Oxford University this week about this vaccine. We had talked a little bit about vaccine. Do you think that this is going to come out sooner than we had expected? And do you think a vaccine is the answer to all of this?
So what the Oxford study revealed, Dr. White, I think, no, yeah, his name is Dr. White. They have a unique technology there that allows them to really ramp up very quickly. And keep that in mind, because I think that is something, aside from the efficacy of this particular vaccine that they're developing, we shouldn't lose sight of, that they have this ability to not inactivate a virus and then inject it and hope that the body mounts an immune system to it, but rather alter an existing respiratory virus in such a way that the body then creates antibodies that will be effective against, in this case, COVID-19. That's the platform that they're working on. They've tried it in now in one human, but they've also tried it in our closest relative in the primate world, which is the macaque monkey. And I think 6 macaque monkeys were tried, or some small number. But then they bombarded these monkeys with COVID-19 and they didn't get sick. So that's encouraging. So what the press is telling us is that this, this technology might be able to bring this vaccine to widespread use. I mean, next step, they're going to test, I think, 6,000 people, but it might really shorten the timeline because it's sort of an existing platform that's already been used in other viral epidemic types of situations. So it may dramatically shorten the timeline, and that's certainly encouraging. Now, to answer your second question about immunization, is that our only hope? I think that the notion of herd immunity is something, as I talked about earlier, that does play upon this immunization issue to some degree, but can also be achieved if a certain number of people ultimately develop antibodies. You can develop antibodies by getting sick, or by not getting sick, but being exposed and having the virus. And you might be lucky and be asymptomatic, or you can get it from an immunization, a vaccine. And I'm well aware by doing a daily podcast that there's not universal love for the whole notion of immunization and vaccines. And I try to be as sensitive to that as I possibly can. I note that there is a push every year for everyone to get a flu shot. You drive down the highway by a pharmacy and they say, stop in and get your flu shot here. You can get it at an airport.
Anywhere.
But the reality is that the so-called flu shot every year, and if you ask in the pharmacy, why should I get this? They'll tell you, so you won't get the flu. Well, that's not true. The effectiveness of our annual influenza immunization, according to the CDC, varies between 20 to 40%. It means that in any given year, most people who get a flu shot will not have protection. And that's published data from the CDC. Now, it doesn't mean that if you have an underlying respiratory issue, you shouldn't get a flu shot, because even if it's 40% effective, that's probably pretty good for you, because if you get the flu, it could kill you. And let's not forget that the flu does kill in America every year between 40 and 50 to 60,000 individuals. So it's just the infectivity of this COVID-19 and how aggressive it can be for otherwise seemingly healthy individuals that makes it such a different player. It's not playing by the rules, and we have to adjust.
Is it not playing by the rules a lot because it's striking everyone differently and we can't quite put an algorithm together yet? So I think that's part of it.
I think the algorithm is making itself very clear. And it is that if you have, as you well know, an underlying condition, your risk of bad outcome is dramatically increased. And what are those underlying conditions? They're all immune related. Type 2 diabetes, obesity, coronary artery disease. These are immune issues. Immune function in individuals who are obese is compromised. Their ability to respond to a vaccine is less aggressive than people who are non-obese. Their levels of inflammatory response is significantly higher, as it is with diabetes, and as coronary artery disease is an inflammatory disorder. So this relationship then between these chronic degenerative conditions, which with all due respect are related to lifestyle choices, is making itself very clear at this point. And when we began getting higher rates of infection with COVID-19 here in America, something very unique was noted, and that was that younger people were ending up in the hospital.
Yes.
And that was a real head scratcher. Why are younger people going into the hospital? I mean, after all, these are young and healthy Americans. And I think it's really valuable to recognize that young and healthy do not necessarily go together in America, that many of our younger individuals are not healthy, that we have incredibly high rates of obesity, we have type 2 diabetes in people in their teens. We used to call it adult onset. We have 8-year-olds now with type 2 diabetes. So these are lifestyle consequences that wreak havoc. Those same lifestyle choices that lead to diabetes and lead to obesity lead to damaging the immune system, basically aging it. So we call that immunosenescence, the senescence of our immune systems. And we can bring immunosenescence on by eating a diet higher in refined carbohydrates, higher in sugar, ultra-processed foods, by not getting any exercise, and powerfully by compromising our ability to get a good night's sleep.
So if you were to, that's very interesting. So we have to kind of reverse engineer what's happening and think about it in terms of wellness. And I don't think wellness is going to be thought of as a luxury anymore. It's not going to be thought as a luxury anymore. We now know that we need to protect ourselves. We need that armor all of the time. So Dr. Perlmutter, you're one of the foremost doctors out there right now. What prescription would you generally give people to protect themselves and to build that armor?
Well, before I give that prescription, I would say, we live in a society that really says, live your life however you choose. And when you develop something, why, we'll fix it for you. And for the most part, medical education is all about that. It's all about fixing problems. So to say what we have in America is a healthcare system is a gross misnomer, because it doesn't deal with health. It deals with responding to challenges in the form of illness. And there's not a lot of care, as a matter of fact, if you really want to get down to it.
Yes.
So I think that the prescription globally for us would be that we revamp our provision of these services to focus on, yes, responding when we need to respond, but to understand the wisdom of keeping people healthy in the first place. It's the right thing to do. We're being called out on that right now in a very big way by COVID-19. This revealed to us the error of our ways in so many respects, not just by not being prepared for a pandemic, but by setting the stage for bad outcome by allowing people to become so unhealthy. Our longevity has been lower than many Western, or rather developed countries in the world, year after year for the past 4 decades. It isn't like that just started. We spend more than twice as much on so-called healthcare than our next country, and yet, the World Health Organization ranks us at 23rd. Interestingly, we were ranked #1 prior to COVID-19 in terms of the ability to respond to a pandemic, but we see how that played out. Other countries were better prepared. Other countries had testing at the ready. They had protective equipment at the ready, and we did not. And my hope is that we learn about responding to a pandemic from this experience moving forward, and we recognize that it is cost-effective and the right thing to do to keep people healthy, and will help us come next pandemic when less people are going to get critically ill. It'll be less of a tax on our intensive care units, and we won't have to worry as much about flattening the curve.
We're getting so many comments. People are really liking what you're hearing because we're not talking enough about this. We're not talking about what I see as a global call to action, and that is to take care of ourselves in a very different way than we had once done before. Let's talk about some of the treatment protocols that are out there now, Dr. Perlmutter. You've talked a lot about ivermectin. Can you tell, I want to talk through some of these so people just get an idea of what's available to them if they do get sick. Are any of these taken prophylactically, or all of the medications and the treatments that we talk about?
Well, we need to talk about these individually, but I think you brought up ivermectin.
Yeah.
And ivermectin got in the spotlight about 10 days ago with a publication by Dr. Kylie Wagstaff in Melbourne, Australia, whose laboratory used ivermectin in COVID-19 infected cell culture. And what that means is this is a laboratory test. It's an in vitro test, demonstrated that in 48 hours, the virus levels were reduced by 5,000-fold. So basically in 48 hours, it was eliminated. Now, that said, as I presented it just like that on my podcast, the questions that started to come up in the feed were, oh, okay, how much should I take? And you cannot extrapolate from a lab test on cells to telling a person, therefore you should take this, because it does not work that way. People have access to ivermectin. It's the pill you give your dog for heartworm. It's given to horses. It's given to humans who have head lice or who have GI parasites. So it has been shown effective in Zika virus and in influenza in humans, but there is no real trial that has happened thus far in using ivermectin in a comparison to, for example, a placebo to prove that it's helpful. Having said that, there has been a study that retrospectively, in other words, looking back, in comparing outcome of people who had taken ivermectin in comparison and were infected with COVID-19, and versus those who had not taken it. And there was some certain advantage in terms of how long it took them to no longer test positive for the virus, being much more aggressive in the people, and much less time in the people who had taken the ivermectin. That is not an interventional trial. It's not like they tried it in a hospital setting and all that. It's just looking back at some of that data. So ivermectin is being studied. We will see what that shows. The good news about ivermectin, and again, I want your viewers to know that I am not suggesting that you take ivermectin. This is a laboratory study only. But I will say the World Health Organization has ivermectin on its global approval list for other applications for the treatment of parasites, which is obviously a big issue in developing countries. So it is globally available, and I think it's extremely inexpensive, but I'll say it a third time, it's too early to make a recommendation.
Yes, good advice. And the first treatment I've heard about was the hydroxychloroquine. What's happening with hydroxychloroquine? Because I saw the study that there was something about a higher death rate than patients who didn't get the drug. Or clear this up for us, because I'm not really sure where the stance is on that now.
Well, the idea of using hydroxychloroquine is not a bad idea. There has been demonstrated effectiveness of hydroxychloroquine, which is a malaria drug, being used originally off-label, now prescribed, of course, for autoimmune conditions. But that said, it does have antiviral activity. It has been shown effective in dengue. It's been shown in West Nile virus as well to be effective. And so, there's a precedent here that it may inhibit the way this particular COVID-19 virus is able to make its way into the cell and possibly inhibit the way then it replicates once it's inside the cell. That was speculation. There were a couple of tests that came out early on that suggested it was effective, especially when coupled with azithromycin in terms of being able to shorten the time whereby a person tests positive for the virus. The new study that was published done at the Veterans Hospital, however, was worrisome in that there was some indication that individuals who had taken it actually either had no change or possibly had a worse outcome. So I don't think it's going to, more testing is going on. It is the #1 clinical trial being done on the planet right now. It's looking at hydroxychloroquine. Why? Because it's so readily available worldwide. So we need to see how that plays out. But I think, it's not a free ride if you take hydroxychloroquine. The Indian Cardiology Association has put up guidelines prior to treating with hydroxychloroquine about how to assess a patient in terms of looking at their EKG, at their history, because we do know that hydroxychloroquine can affect heart rhythm. It can prolong the QT interval. What I'm saying, it can lead to heart rhythm issues. And I think another thing that has not been talked about but needs to be talked about with both hydroxychloroquine and chloroquine is that there are a large number of people on this planet who have an enzyme defect that puts them at risk for taking hydroxychloroquine. So this is the most common enzyme defect, and if you carry it, then if you are taking hydroxychloroquine, you run the risk of developing something called hemolytic anemia, where basically your red blood cells just shatter, and that can be lethal. And that's an enzyme defect that affects 400 million people on the planet. So a simple test for that as well. And so I think we need to consider everything we do in terms of risk and benefit. If benefit is really over the top, then maybe we're in a place to accept a little bit of risk or maybe more risk. But if the benefit is kind of marginal, then why accept risk? We want to look at both of those.
How about Arbital? I know it's an anti-influenza drug used in Russia. Can you tell us more about that?
Sure. So Arbital is, as you mentioned, it's been around for many years, used very commonly for influenza in Russia, and it does have activity against other viruses. And the mechanism whereby Arbital works is kind of unique. It deals with the ability of the membrane surrounding the virus, the ability of that membrane to then fuse with the membrane of our cells and then inject the virus into our cells where it then reproduces. There is quite a bit of use of Arbital in Russia, certainly, and in China as well. So, recently there was a study that indicated that looked at the comparison of Arbital with a couple of more commonly used antivirals in China, lopinavir and ritonavir. And they demonstrated that, again, the time for having less, where the time until you were tested virus-free was shorter with the Arbital than with that combination drug antivirals that is used in Japan. So, it's widely available, and I think that, borders shouldn't be considered, politics shouldn't be considered at a time like this, that if, a country has something that looks promising, by all means, let the rest of the world know about it. And we're seeing that happen, and it's very encouraging to see that.
What about the use of transfusions, plasma transfusions? I know they use that for Ebola. Are we getting involved in that now in hospitals?
Yes, that is, that's really, I think, taking off even at the local level. And, the beautiful thing about that is it allows people who have recovered, we call them convalescent, their plasma is called convalescent plasma. It allows them to give back. They give their blood, the plasma is harvested, that's rich in antibodies directed against this virus that will then treat people that likely they will never know, and it's a really wonderful thing that so many people are asking, where can they go? And we're seeing that, you know, even local community hospitals seem to be getting involved in, you know, as part of research. I know the Mayo Clinic's doing a big study and has, you know, championed a lot of local hospitals being part of that study, because the technology is really quite straightforward, quite simple. Blood typing has to be done. Plasma has to be extracted, which means basically take the blood and stick it in a centrifuge. A few other things for purification and to make sure that there are no other potential things being transferred. You have to screen the blood. But this transfers what we call passive immunity, which means now you've received this, you have specific antibodies against this virus. If you get it, then it's likely that you won't have as bad of an outcome. And if you're sick and in the hospital, it might help you with your recovery. It's very straightforward. It was used, as I mentioned earlier, in a form back in the Spanish flu in ultimately around 1920, 1921, it was used.
Mm. And then how about, I know one, I think the common name is Pepcid. It's famotidine. What is the problem?
Yeah, so that was an interesting interventional trial that was discussed a couple days ago. And I don't think there was much to that. I think that the construction of how that trial was performed was not really adequate. And I think that, you know, mechanistically, I see, you know, we can understand where they're going with respect to receptors and also even perhaps pH, but it was more a receptor geared approach. You know, I think that what we're seeing is, gosh, we've probably talked about 15 things, 20 things already tonight, that people are looking at everything that has, you know, some possibility, whether it's, you know, Pepcid or high dosage intravenous vitamin C, which is being looked at in a Chinese study, 12.5 grams twice a day.
So happy to hear that. Yeah.
Pardon me?
I'm so happy to hear that.
Yeah, or and even, you know, various oral things and even traditional Chinese medicine. These things are being evaluated in well-constructed studies. So nothing should be off the table, provided it's not, you know, doesn't have a high risk quotient.
Are there any of these treatments that you find that will have the most promise? Is there any that really are standouts for you?
Well, before we get to treatment, I want to emphasize what we've talked about tonight, and that is that we have the opportunity to rejuvenate our immune systems. You know, I'm 65 years old. I cannot turn back the chronological clock, but I can turn back the biological clock. So I can amplify immune function and regain more youthful immune cells by involving myself in various types of things that help my body get rid of aged, less functional immune cells. We know that our immune system ages and becomes less functional. So even fasting, for example, because it amplifies a process called autophagy. Autophagy is bringing out the garbage man. So that go around and look in the body to see what it's time to get rid of. It's like, you know, time to empty out the garage of all that stuff. And it gets carted away. And then newer cells will populate your immune system, younger functional cells, young in terms of activity. We can do that with fasting. We can do that with intermittent fasting, caloric restriction. There are a variety of senolytic products out there. Seno meaning old, lytic meaning breakdown. There's one called Fisetin, F-I-S-E-T-I-N. There is quercetin, which is a flavonoid. So there are various things that we can do that can help amplify our immune systems. And we can stop challenging our immune systems by getting a good night's sleep, by cutting out our sugars and refined carbohydrates and ultra-processed foods, by getting exercise, reconnecting with nature. All of these things tend to reduce inflammation, tend to enhance immune function. Meditation is a wonderful, free, and we've got time right now, powerful way to enhance immune balance. So these things are all out there. And I think finally I answered, that was a question you had asked me a long time ago. What is the laundry lists.
Yes, I mean, I think that's what people, based on the comments that we're getting also, Dr. Perlmutter, they really want to walk away. I wanted everyone to know that there are treatments, that there really are, we are progressing, we're learning, we're growing all of the time, and we're really forward moving. And I also want people to know, and this is a big part of why I developed the show, is I don't want people to feel the fear. I want them to feel empowered.
You
and
bet.
I want them to know that there are things that we can do. We can shift the consciousness of this. We really can. So what would you say to those people out there? I'm thinking again of the woman I saw in the store the other day who was so frantic and so tired and so afraid of everything around her. What would you say to those people out there that really still are feeling afraid and stuck, and there's so much going on and so many unknowns? And I think that's what it really is.
I'd say the first thing is to turn off the television. Get an update, watch the news, go online, read the news, whatever program or website you think is valuable, great. But then turn it off. But if you keep that stuff feeding into your psyche day in and day out, 24 hours a day, it is nothing but fear-inducing. In the state of fear, of fight or flight, we compromise our immune system. So basically what I'm saying is the more you watch the news, the less likely you are to have a good outcome. Think about it. The more you ingest fear, the more you compromise your immune system, the less likely you are to do well if you ultimately get this virus. So I think that people should embrace the notion that they can be the arbiters of their health destiny.
Beautiful.
As it relates to COVID-19. We live in a country whereby we just sort of think, well, I'm going to do whatever I want. If something bad happens, I've got the hospital, I'll end up there. I might need a ventilator and then I'll come home. Well, 70% of people going on a ventilator die. So that whole notion should, make you want to question the idea of living your life come what may, and if you get it or not. So we should feel empowered that we can chart our destiny based upon what our lifestyle choices are. We control how our immune system works. Sure, there are some genetics involved. Sure, our past medical history plays a role, but we can rewrite the past medical history. We can't take the diving board off our gene pool, but we can rewrite our past medical history in terms of how it influences how we are today. And I would also say that this is not a sprint. This is a marathon. We're not going to be done with this, despite the fact that various states are opening up because they think this is the time to do that. This isn't going away anytime soon. We're going to be dealing with this in one form or another for months and months. Is it until we develop a vaccine? Perhaps. I don't know. But I think you got to pace yourself on this one and take a deep breath. And really, I think one of the most valuable things to do is to keep a gratitude journal. Because when you keep a gratitude journal, then the glass, you're looking at the half full glass. You're not focusing on the fact that it's half empty. Yeah, things are bad. Sure they are. But maybe there are people in your house that you would not have spent time with. My mother-in-law moved in with us. It's been wonderful. We've been together now for 6 weeks. And, beginning to even develop a much deeper appreciation for nature, for the value of exercise. And for me, it's, other things, poetry and gardening. I haven't really done much of over the years, and now I'm getting into doing that. So I think a gratitude journal will go a long way to distancing ourselves from fear. This is exactly what our book, Brainwash, is about. Oddly enough, came out on January the 15th, about making lifestyle choices to calm down the fear center of the brain. And, it turns out now, in light of what's going on, it's been picked up into 18 countries around the world.
Fabulous book.
It says that. It says basically you control your destiny.
And I want everyone to really hear that. I want you to hear what, one of the best experts in the country are saying. You can control this. You can get a hold of this. And I think what people need to know about gratitude is that sends signals in our body that are very positive and very good for our health. So thank you